Okay. Um, I am Dr. Pham, and I am one of the heading faculty here at the University of Utah. And today we will be talking about when should I be concerned about a CSF leak. And this is intended as kind of a more surface overview, but it's a topic that not everybody knows about. So here we go. So to start, here's some anatomy. So the spinal cord, which is this part in this graphic here, that kind of tan part that I have circled in orange, it is covered by a few different layers. And these layers that surround the spinal cord are called meninges. And inside of those meninges, kind of surrounding that spinal cord, there is fluid called cerebrospinal fluid. And this kind of protects the spinal cord. It's also present in our brain, and it gives us that kind of buoyancy or floating kind of for that brain and spinal cord. And so the dura I have highlighted here in red, and when fluid that's normally supposed to be on the inside of the dura leaks outside, which is shown here with the little blue arrow, then we consider that a CSF leak, and this can occur in a variety of ways or places. And as you can see in this graphic by Farb et al., there are a lot of different places along this pathway where you could see these. So what is a CSF leak? Well, it's a leakage of spinal fluid through the dural membrane in one or more places, and it causes a lower than normal volume of CSF, and it can cause brain structures to become displaced. And so we turn to the International Classification of Headache Disorders, 3rd edition, which is where all of the different headache disorders are, and their diagnostic criteria are listed. And CSF leak is under the category called secondary headaches. And in particular, there's a part that talks about pressure disorders of the cerebrospinal fluid. And so that's kind of where this lies. And so the diagnostic criteria, for the technical term, headache attributed to low CSF pressure, and there's some subvariants of that, basically requires either or both of the following: either low cerebrospinal fluid pressure, so less than 60 millimeters of fluid. Normally people are somewhere like around 12 to 20, give or take, but less than 60. So less than 60 would be 6. So 12 to 20 would be like 120 to 130, depending on if you're using millimeters or centimeters. But yeah, less than 60 would be low. And that would be determined if somebody did a lumbar puncture and measured the pressure upon, getting to that spinal fluid. Or both have seen evidence of a CSF leak on imaging. And the other important piece here is that the headache has to have developed in relation to time-wise with either the low CSF pressure or the CSF leakage that you've seen on imaging, or have led to the headache itself was what led to its discovery. So, and then you can't have another headache disorder that better explains the symptoms that you're having. So, quite a bit of criteria to kind of get to this as a diagnosis. So, and we'll talk a little bit later about how to test for it. So what causes a CSF leak? Well, it's due to a leak in the tear in the dura. And it can also be due to outpouchings of the meninges. So those layers that surround the spinal cord, if they form little outpouchings off of it, fluid can collect there. And we think of those as Tarlov cyst and dural ectasia. And And then also it can be due to what we call CSF venous fistula, which is basically this abnormal communication between that space where the spinal fluid is supposed to be and nearby veins. And so that spinal fluid ends up in this fistula rather than where it's supposed to be. And then you can also see this following a lumbar puncture. For example, having this done for medical tests or for pain control during labor and delivery. Epidural, an epidural for pregnancy, it shouldn't poke into the dura, but sometimes it can, unintendedly. Or the spinal anesthesia that is used often in C-section actually does go through the dura. And so you could see leaks following those as well. So who gets a CSF leak? Not a ton of people do. It's not particularly common, but you can see up to about 4 to 5 cases per 100,000 people. This is about half of the frequency of which people have brain bleeds due to aneurysm. So it's not particularly common, but it does exist. When it happens, most common in women between 35 and 55 years old. And there are some risk factors that make people a little more likely to have spontaneous leaks where there's not really a clear cause found. And those would be people potentially with connective tissue disorders such as Marfan's or Ehlers-Danlos syndrome. And then also in people that have bone spurs or they have vertebral discs that have herniated and calcified, if those structures are rubbing against or poking into that dura, sometimes that can be a source as well. So what are signs and symptoms of a CSF leak? By far and away, the most common symptom of a CSF leak is what we call an orthostatic headache. This is a headache that is worse upright. And we're not talking about like worse for a minute or two upright, but really like you stand up and you within minutes, 30 minutes, 15 minutes, an hour or so, end up with this really, notable headache. And when you lie flat, it nearly goes away or goes away completely. We do see in people with migraine or even people with like POTS or similar sort of conditions where their autonomic nervous system isn't functioning as well, that they can also have headaches worse with standing. It's usually a little bit more of a temporary sort of thing and not so cut and dry. Often these patients feel really bad upright and feel completely normal or close to lying down. So 93% of people with a CSF leak have this type of headache. Very small percentage of people could have a CSF leak and have a headache that really doesn't have any positional nature to it. And about 2% can actually have the reverse where they feel worse lying down. But that headache worse upright is the most common symptom. As you can see in this table, there are several other symptoms that people can have. Dizziness and vertigo occurs in about 50% of people that have a CSF leak. Just because somebody has dizziness or vertigo doesn't mean they have a CSF leak, but we do see that in people that do have CSF leak at time. I would not think about a CSF leak though if there isn't a headache, or in particular this headache worse standing up with just vertigo alone. Other symptoms people could have is muffled hearing, ear fullness, increased or decreased hearing, ringing in the ears, sometimes nausea and vomiting or a sense of being off balance, pain in the back of the neck, some cognitive impairment, fatigue, sensitivity to light or sound, blurred vision, feeling some numbness, tingling, or pressure in the face. And then the really least common symptoms would be pain between the shoulder blades, some abnormal sensation of taste, low back pain, even a type of dementia called behavioral variant frontal temporal dementia, weakness, kind of small brain bleeding, sometimes larger, blood clots in the draining vein or what we call the sinuses. And then double vision, and then even problems where the spinal cord either has abnormalities within the cord or it herniates, meaning it kind of comes down below where it's supposed to in the skull, coma, or where people are having impaired level of consciousness, and hemifacial spasm. So there is quite a range of symptoms that one might have with a CSF leak. And so how is it diagnosed? Well, we had the criteria that we looked at before. And if and so, you know, that required either a lumbar puncture or imaging or both. And so if there's a really compelling history based on how the headache is behaving, you know, it may push us to do some of these studies. So we can have some findings on brain imaging. And most of the time you will see some sort of findings, not always, but most of the time there will be some sort of finding on a brain MRI. That could be where that dura that lines the spinal cord, it also lines the brain, can show enhancement. So it lights up bright. On an MRI, there could be collections of fluid just beneath that dura. The vein structures could become engorged. You could see sagging of the brain, pituitary enlargement even you can see. And then the optic nerves, so those are the nerves that relay information from your eyes back to your brain that help you see. You could see a decrease in the volume of kind of that lining of that optic nerve. Only about 20% of patients with a CSF leak have normal imaging. So in most cases, you do see something. And then you can also look at the spine. So, you know, if the brain imaging is suggestive of a leak with these findings, then you want to go find where that leak is if you can. And so then we look at the spine. And in about half of patients that have a CSF leak, we can see a collection outside of the dura where that leak is present. And so spine imaging is, you know, the gold standard would be either MR or CT myelography. And that basically involves going in and injecting a dye into that CSF space and looking to see where that dye comes back out, to see if the dye comes out where it's not supposed to, then you know that there's a leak and you can find out that that spot. So not a totally benign procedure because it involves sticking a needle into that area, much like a lumbar puncture would be. And so the decision to look for these really needs to be made thoughtfully so that we are not causing more harm than good in trying to find these. If there is not an obvious leak, but either the brain imaging is convincing for a leak or the history is really convincing for a leak, there's really not anything else to explain this. Sometimes we would go one step further and do a digital subtraction myelogram or a dynamic CT myelogram. So as opposed to lying flat on your stomach often is how the regular myelograms are done. They have you on your side or move you in different positions during this. But otherwise, it's the same sort of process. And this is looking for the CSF venous fistula. So as I mentioned before, where there's this abnormal connection between where the spinal fluid is supposed to be and the blood vessels. And those can be particularly tricky to find. And so often need this more advanced imaging to find. And then certainly a lumbar puncture could be done and measure the pressure. And we see that in those diagnostic criteria that's one of them that you could have. Typically we don't do this. And typically lumbar puncture is reserved for mostly resource limited settings where there isn't access to an MRI machine or a CT scanner. And the reason why is because if we're concerned that there already is a leak we don't necessarily want to go and drain off more fluid in such a way where the only information we're getting is a number, the pressure number. During the CT myelogram, we get better quality images, or the MR myelogram. Some providers even will go in and patch where they do that myelogram to kind of make sure that there isn't a leak from doing that study, but not something we can do as readily with lumbar puncture. So it's just not something we use as often. So then the next question is, how is a CSF leak treated? So there is conservative treatment that can be done. It includes bed rest. So basically you're lying flat, waiting for the area where the leak is to kind of close on its own. Staying well hydrated orally, drinking caffeine, and then abdominal binders can help. And then if those don't work, then we use things, the gold standard then would be a blood patch. And so this can be done either in a non-directed or a directed fashion. Basically what this means is, if there's compelling enough evidence that there is a leak and we can't find it, you can go ahead and do a blood patch with kind of a large volume to try and close a leak that may be somewhere, but you don't know where it is. And basically, blood is collected from somewhere else in your body. And then, as you see in this diagram, that the needle goes in just to on top of the subdural space. This epidural space is the space right on top of the dura. And that blood is then injected back in. And so that's where this kind of purple area is there. So that would be a non-directed blood patch. You don't know where the leak is. In a directed blood patch, you see the leak and you target that specific area. Sometimes a glue called fibrin glue is also used for patching. Usually this is done if there is a spot that is found, the leak is present there, and it has been patched with a normal blood patch, a directed blood patch a few times, and isn't holding well, then sometimes this fibrin glue patch will be used in this area. Fibrin glue is not done everywhere at this point. It's an emerging therapy. And so not every institution will actually do this. Some places they do it. And then when there's something that structurally, like a bone spur or something, for example, that is causing recurrent leaking because of its physical contact and rubbing or poking at this dura, then that sometimes requires surgical repair. So then that would be a neurosurgeon going in and fixing, removing the bone spur or whatever it is that is poking at the dura so that it no longer can do that. So those are your kind of main treatments. And then complications of CSF leaks. Well, if these leaks go on untreated for a long period of time, which sometimes they can for years, you could end up with a hematoma in the subdural space, so bleeding in that space, spinal cord herniation, coma, and then this behavioral variant frontotemporal dementia. Even if this leak is caught and treated right away with the blood patch, you also can have a complication of treatment, which is rebound high intracranial pressure. So instead of low pressure, now you have high pressure. And this can be quite challenging to treat as well. And we worry about this because when there's sustained high pressure, this can affect your vision in a negative way. And so this can be kind of a complex disorder to treat because of the complications that you can get from either not treating it or from treating it as well. The bottom line is that the decision of how much workup should be done and how aggressive should treatment be needs to be really thoughtful, because there are complications of doing or not doing, whether that is treatment or workup. And so that you just have to be really mindful, and often involves the whole picture of kind of the history and the studies, and oftentimes discussing with colleagues and getting their input as well. And so really something to be mindful and thoughtful about. So the question, when should I be concerned about a CSF leak? The times where I would typically be concerned is if there is this orthostatic headache, this truly orthostatic headache that's not just temporary, but really durable. Every time you're up, it's bad. Every time you're flat, it's gone or almost gone. So that kind of headache. And then you have had one of these, potential risk factors, like you've had a lumbar puncture or spinal or epidural anesthesia recently, or you have a history of connective tissue disorders or hypermobility, or a history of bone spurs or other, herniated discs, things like that. So if you have good reason where a leak could be present because there's a mechanism that could have it present there and the history fits, that is when I worry about it. Traumatic injuries, things like that could be times too, whiplash injuries. So really things like that would be, you have the right circumstances and the right type of headache, then that's when I worry. The bottom line is, if you are worried about this, discuss it with your doctor. If they don't know, they can refer on to a headache specialist. Or if your doctor is a headache specialist, discuss it with them. And really the whole picture will be taken into context, and it can start discussion to determine if this is something, if your symptoms are something that really warrants workup, or if there's something better to explain them. And if it does warrant workup, how to approach that in the most thoughtful and safe manner. And that is really all I have. So I'll open up the rest of the time